Hi everyone, we are going to introduce our critical design research about the mini-grid community's emergency response during the pandemic. I'm Marco and this is our group presentation. Our presentation has four main parts: background, key issues, important data, and finally our design strategies and summary. First, let's look at mini-grid. It's a remote Aboriginal community in Northern Territory, Australia. There are about 2,500 people here, and more than 13 languages are spoken. The local healthcare and education systems depend a lot on outside support. After COVID-19 hit, the government cited Maningrida as a biosecurity quarantine zone. This means strict control of people and materials going in and out, which made it really hard for the community to get supplies and health information. Here are the main problems Maningrida faces: geographical isolation, multilingual environment, dependency on resources from outside, and big information barriers. These issues all make it much harder for the community to respond to emergencies like COVID-19. Let's break down the causes. First, Maningrida is far away from big cities and relies on supplies flow or shipped in, so logistics are very difficult. Second, people here speak many languages, so health info from the government often doesn't reach everyone or isn't trusted. Third, the community's health status is complex and risky, so any disruption is more serious. During the lockdown, there were several key problems. Most government health info was in English, so many people couldn't understand it. There were big shortages of medicals and daily necessities, and the price of basics went up 17%. The government gave a one-off $250 subsidy, but it wasn't enough. When the vaccine first came, not many people got it because info was confusing and the supplies were limited. However, when others started spreading the message in local languages, the vaccine rate jumped to 65% in just 4 days. And long-term isolation also caused a rise in anxiety and depression in the community.
And for this part, I'm responsible for the part about serious cases and message. And during COVID lockdown, many graders faced three main problems. First, medical resources could not arrive in time. And second, there were language barriers, so health messages were hard to understand. And third, people did not trust information from government. Because of these problems, we start our research. Series and frameworks help us find what matters most in indigenous communities during emergencies, cautious of serious work in real life. Finally, research methods help us apply these ideas in our projects, even if we can do fieldwork. And this first theory is humanitarian design from IDEO. It's people concerned with respect and empathy at its core. It faces emergencies and situations with limited resources. And from Mandy Grader, this framework tells us our solution should be simple, practical, and direct. During lockdown, our communication breakdowns. So the key points is to solve urgent problems quickly and make people feel careful. The second theory is decolonial design, and it starts from the community's own view, not from a Western perspective. It lets the community tell their stories in their own languages and supports cultural adaptation. Maningrida has many languages, and people are conscious about outside politics. And this theory reminds us to respect community voice and let local people lead. The third theory is indigenous health access. It says health services should feel safe and trustworthy to local people, not just be physically available. True access needs language, customers, and trust, and in many greater official health information often lacks unfamiliar and hard to accept. So this framework tells us to design with culture, trust, and local languages in mind.
And now the first case is Orange Sky Laundry. This team brought mobile laundry, hot showers, and space to connect to people experiencing homelessness, including in remote indigenous communities. Their service restores dignity, make people feel seen and respected. It is simple and flexible, fitting emergencies and mobile situations. Volunteers build trust with community members through conversation, not complex programs. This case shows the value of human-centered, low-barrier design.
The second case in health messaging is the Northern Territory. The community members made COVID health videos in their own languages, and messages from female people in female languages are easier to trust and understand. This is a good example of decolonial design, not just a translation, but letting the community truly speak for themselves. And the third case is the Meningitis vaccine campaign. Community elders use the local languages to encourage people to get vaccinated, and 1,300 vaccines in 4 days. And this works because people trust the speakers and shared the same culture. It shows cultural acceptability is very important in health design. And finally, our method, because we can't visit in person, so we choose two indigenous research methods. First is the co-creation, where we use existing interviews and stories to collect local languages and ideas and simulate co-design, avoiding decisions imposed from outside. Second is yarning, which brings indigenous storytelling and conversation style into the design process. Yarning helps us build cultural connection and reduce communication barriers. This method helps us put theory and experience into practice and stay close to the community needs. And the next part is the set and the residence analyze.
Meningitis is located approximately 500 kilometers east of Darwin and 300 kilometers northeast of Jabiru. It lies along the central north coast of Arnhem Land at the mouth of the Liverpool River facing the African Sea. As shown in the first image, the road network in the Meningitis community is very sparse, with residents mainly concentrated in the northeastern corner of the community. The surrounding area consists largely of undeveloped forest and wasteland, with extremely limited transportation options, low travel efficiency, and few alternatives for mobility. The image on the right illustrates that the region's connection to the outside world relies almost entirely on a small airport in the southeastern corner and a single road across point. This high dependency on a single road results in very low transportation reliance during emergencies. This image presents the abundant geographical environment surrounding Meningitis. It shows that community is surrounded by vast forest area and coastline, with no nearby towns, infrastructure, or pregnant settlements, making it a geographically highly isolated area. During public health emergencies, such as pandemics, this isolation severely limited contact with and support for the indigenous community, posing major challenges to transportation of supplies and delivery of medical assistance. The population distribution in the Maningrida region is characterized by three main features. The first is relatively small population. Maningrida has a total population of 1,518 people, primarily composed of indigenous residents. Overall, the population density is low. And next is uneven residential distribution. As shown in the uploaded map, residents are mostly concentrated in the northeastern part of the community, forming a locally high-density cluster, while the surrounding area remains sparsely populated. The third point is the presence of multi-generational households in the region. It's common for indigenous families to live in multi-generational homes, while several generations share limited housing space, increasing the risk of virus transmission due to overcrowding. The Maningrida region has only one medical center located in the southwest, resulting in severely limited healthcare capacity. This poses major challenges during a pandemic. First, medical resources are scarce. There are not enough beds, staff, or equipment, and no paper solution facilities, raising the risk of cross-infection. Second, emergency transport is difficult and slow. Patients must be transferred to Darwin, but long distance, high cost, and the seasonal roads of flight distribution delay care. Third, the healthcare workforce is small and overstretched. If any staff feel ill, the system may fall. Lastly, indigenous community factor worsen the situation. High rates of chronic illness, limited medicine access, language barriers, and the low vaccine coverage all increase the vulnerability. Manigrida's hot and humid climate poses several public health risks. First is the high heat and rainfall promote mosquito-borne disease and virus transmission. Second, prevention is harder. People avoid masks and gather indoors, increasing spread. Third, limited healthcare resources are easily overwhelmed, while more cases of head-related illness and worse chronic conditions. Finally, extreme weather can disrupt drugs and medical supply chains, weakening emergency response.
Now let me analyze it from the perspective of local residents. Maningrida is located in the Northern Territory within around 2,500 residents. About 93.7% are Aboriginal people. That's roughly 2,300. The community is made up of small family groups living across town and in surrounding homelands. People mostly belong to four main language groups: Barara, Nanjubana, Kuninjuku, and Kim. Maningrida is known as one of the most linguistically diverse areas in Australia. The belief system here is based on the dreaming, a spiritual way of seeing the world that connects people to land, animals, ancestors, and the universe. The community is socially organized by clan and skin groups. This system guides relationships, roles, and responsibilities within the community. To be more, the Maningrida is also famous for its beautiful traditional arts, including bark painting, carving, and weaving, such as fish traps and baskets. Now, I would like to share four major issues the residents faced during COVID-19. The first one is about language barrier. According to the Australian Bureau of Statistics in 2021, Barara and Nanjubana are the most spoken language in this area. Most residents do not speak English, so when the pandemic started, health information and emergency updates were not easily understood. This seriously delayed community response. The second one is about the lack of trust. There is a long history of mistrust between Aboriginal communities and the transport system. A 2013 study by Sherwood pointed out that colonization caused deep trauma. Land was taken, culture was suppressed, and the people were excluded from services. the history still affects trust in health advice today. And the third one is the cultural barriers. In Manarida, people prefer face-to-face communication. They rely on oral traditions and the group meetings, not written notice or online news. Most COVID information comes through digital platforms like website, apps, and printed posters, which didn't fit their way of life. But when local elders work with their health staff and use local language to explain the vaccines, things change quickly. In just a few days, 65% of the adults were vaccinated. This shows how powerful cultural connection can be in public health. The last one is the low digital ability. Even if some residents wanted to read English or follow online news, many lacked of digital skills to do so. ABC News reporting 2021 showed that during a long-term internet outage in Maranrida, many people didn't try to call for help and use government apps because they didn't know how, or even they exercised. The 2023 Digital Inclusion Index confirmed that remote northern areas have the lowest digital skills in Australia, and the Aboriginal communities like Manaridas score even lower.
Based on our research, our design principle is clear. The community must lead the response, design should respect the cultural, and the solutions need to be sustainable. We use humanitarian and decolonial design thinking, and encourage co-creation and learning, which means talking and sharing stories in a culturally appropriate way. To sum up, the three key principles for future design are: the first one is community leadership and cultural sensitive and sustainability. All our future solutions should follow these principles to improve Manigrida's emergency response ability and resilience. That's all. Thank you.